Hello, everyone, and welcome to the CoROM podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric O'Kelly. This week, we are with Eirik, Holmstrom, and Laszlo Hegedus. Lads, welcome back to the program.
Thank you, Eirik.
Thank you.
Both of you lads have been a guest before, but tell us a bit about what's been keeping you busy.
So recently I was involved in a law enforcement competition in Budapest. It was for international police units from neighboring countries, and I had the opportunity and the privilege to organize a tactical medicine phase in the competition. That was basically a direct threat care under fire phase that we did for 2 days in Budapest. It was very, very interesting. Very useful for the police units as well, and it was very, very fun organizing it and running it through.
For the past fortnight, we have run the RMLS course, the Remote Medical Life Support course, and the iCare course, Intensive Care for Austere Remote Environments, for some EU SOF. And this week, we have the APIS, the Ultrasound course, and TrotMed for Soft Medics course. So, Eirik, describe your experiences whilst teaching on these courses.
I really love teaching dedicated personnel, and this unit from the EU South country here, they are it's amazing because they are so dedicated, they are so willing to learn, they are so motivated. Not that other students that we don't have are motivated, but these guys, they want to learn. They want to stay up late almost and train. So I really enjoyed these past 2 weeks and this weekend. And it's just an amazing opportunity to teach. And I think that a lot of these soft units, they train a lot. They do a lot of training. And what we've been focusing on the first week was the RMS, which is basically more non-combative injuries, and the feedback we got was pretty also amazing.
Yeah, they seem to be keen on and happy enough. Laszlo, how's your experience?
Well, I just jumped in for the last week, but the experience was very nice. I was very, very delighted to see how open the soft guys are to accept new knowledge. I was delivering them some improvised medicine lectures, and they really, really enjoyed it. And I really like to spread the gospel of doing more with less. And basically, as always, we just looked what do they have in their bags and how can we use various equipment and in more ways than imagined. And I was very surprised when they asked today in the last hours to do some moulaging training, because if we think about it, soft medics, they're not just medics as well, they're educators. So these are the guys who teach the combat lifesavers, the combat medics. And I do believe that giving them Moulage training and how to organize simulations would be very beneficial for themselves and for their units as well.
Yeah, I saw they approached me last week when we were doing the training, the field exercise of the iCare intensive care program. That's when they asked me if I knew any companies that we could make Moulage course.
Exactly, and it just popped into my mind now that how funny is it that yesterday we had an improvised medicine class, and today we had an improvised Moulage class, because the whole class was about how to improvise and do Moulage quick on the fly, because we know that many times these guys have to push through 20, 30 guys at the same time, and they don't always have equipment in the field. And basically, it was most about how to improvise the Moulage, like from the kits they have, or basically from random things that you can buy in the store.
One of the reasons I started this college is to push for the excellence that I saw as a Green Beret, excellence in training and being able to teach. And it's great as Dean Emeritus, and I see the next generation of CoROM faculty push forward, and I'm seeing this excellence continue. It's great to teach soft medics because they're motivated anyway, but it's also quite lovely to sit in the back of the classroom and watch the two of you get up front and make some waves.
Well, thank you so much, Aebhric. I really appreciate it because you've been my mentors ever since we met in Germany. I always looked up when I got you down there for the first time. I think it was in 2016 or
2016.
when you did the tropical medicine course. And I think we really connected, and I looked more into your organization, and I was already starting to think this is something I want to be a part of when I retired from the Norwegian military. The top men that you taught in Germany in ISTC really brought me into this tropical medicine, and this is what we've been doing the last 2, 3 days here. Thinking about the tropical medicine is something that we have more and more need for. When these kind of people deploys around the world, it's not only, as we talked before, Africa. Tropical medicine is now coming more and more widely spread because we have malaria in Germany, we have malaria in several other countries, and also some other that we call tropical diseases who are spreading more and more due to the climate changes. And as you said today, in Africa, when we are in Kobosho in Kilimanjaro with Dr. Francis Akita, they don't call it tropical diseases; they call it just medicine. And that's maybe something of which we are incurring more and more also in Western countries. It's going to be more common than it has used to be. So we need to learn more about it. That's also why when you addressed me a long time ago and told me to take the tropical nursing diploma, that was really great.
The DTN is a good reference to draw from when we are teaching tropical disease because these nurses that are working for MSF or for the UN or for the WHO, they're in country often by themselves in these district health clinics that haven't much at all, and they're able to provide care, improvise, and know that evidence-based medicine is still applicable in austere environments. And Laszlo, we got to get you into that DTN program as well.
Absolutely, absolutely. For like the past, I would say 15 to 14 years, I was way deep in tactical medicine, operational medicine, all these things, and I think I have reached a point where I can see like a bit beyond, and I see that there's so many things missing from my knowledge base, and definitely tropical medicine, deep clinical medicine, critical care medicine is one of those, and I'm really looking forward to widen my range of knowledge, especially in tropical medicine. And as Eirik said before, this is something that is getting more and more close to home, as you can see malaria cases in Italy, Greece, and I'm really looking forward to go doing clinicals in Kibosho to see all these diseases first-handedly.
The only downside is that I think that they are eradicating falciparum in Africa as we speak. I heard some rumors about now the vaccine is being prepared for adults also.
2 vaccines.
2 vaccines, yeah. So, but malaria will be malaria, and as Jason Jarvis, fever of unknown origin is always malaria until proven otherwise. That I think the soft student that we had now this week was really you were hammering that down to them.
I encourage them to tattoo that somewhere, but I'm not sure if they'll follow through with that. And we've hit the ground running. So we redeploy at the end of this week back to the office and then again head out to another soft unit here in Europe where we're doing 3 APIS courses all in a row. Eirik, you helped set that up as well.
Yes, that's 3 2-day APIS courses from another soft unit in Europe. And I think that APIS or ultrasound in general is getting more and more momentum. People are actually seeing that it's not for doctors and in hospital, the big machines. You can actually use it quite well on several different, how should I put it, investigations or, well, remember, ultrasound is not a tool that you diagnose out of, but ultrasound is a tool that you confirm your diagnosis. That's at least my task on it. You don't want to spend a lot of time on the point of injury using ultrasound, but as we are moving more and more into prolonged field care or damage control, like in Ukraine with the stab points and keeping the patient for a longer period of time, the ultrasound is an excellent tool to confirm or to investigate more when you have the time in what's causing this patient to suffer or as you taught today, when you told how to look for fractures.
There's a lot of evidence in that, and you can look most parts of the body for problem sets with the ultrasound, but it's fun to teach the soft guys the musculoskeletal because we have so much musculoskeletal injuries in our job and our day-to-day, and it's great to give them that tool to be able to assess for a fracture versus a major sprain on the ankles.
Yeah, and also as I think it was today or yesterday, we taught some nerve blocks. Because as you said, Aebhric, in the old days, you did femoral nerve blocks without ultrasound and just try to find the landmarks and do the nerve blocks. Today, it's more and more safe, and you can do much more ultrasound-guided nerve blocks, which will really help soft medis out there. The last one you taught today, I think it was the
Posterior tibial.
yeah, which you said that is the most common injuries, and doing that nerve block.
It's my second favorite nerve block, femoral being the first, but the posterior tibial nerve block is fantastic for soft because we have blisters. We get blisters on our toes and we get blisters on the bottoms of our feet. And this one block will do the majority of the bottom of the feet. And I know there's doctors in CoROM, I won't mention names of Tom or Chubba or anyone else whose eye is twitching at the moment because they're saying, no, you need the full three blocks. And I think with just this PT block, this posterior tibial block, you're getting 95% of the bottom of the foot. It's safe. You can't bollocks this at all. We used to do it blind. And today we're using the ultrasound probe to see precisely the nerve bundle and then we can watch the 27 gauge needle go in directly to the nerve bundle and relieve some of the pain for these soft guys.
Absolutely. So I think that more and more soft units. I talked to another EU soft unit today, and they were very interested in knowing what we taught in the ultrasound courses because I think we are spreading word. As you said, we are doing 3 2-day courses in German. As we see now, that ultrasound is coming more and more pre-hospital, and as a matter of fact, I was speaking to another European soft community today who wanted to know more about the APIS, and they are also looking into the possibility of doing an APIS course because I see that more and more of the users are buying the ultrasound. It's not cheap as chips, as you usually say, but they are affordable. I would use that word, affordable. And as I said, we are teaching 3 2-day courses for another soft unit, and then we also have another one in another country coming up in October, I think it is. So we're getting a lot of momentum on teaching the ultrasound. On that note, we are also getting a lot of momentum on other courses like the prolonged field care or the AEC course. So we have the AEC course coming up in Norway, and for you listeners out there, there are still some places. Just go to our CoROM website, corom.edu.mt, and look at the calendar. And that's important in Norway. And I just agreed on a Polish company that we're going to do 2 or 3 AEC courses in Poland next year in January and March and April, I think it is. So the need for not only ABIS, but the need for prolonged field care for the military and AEC for the civilian is something that people are seeing more and more need for.
When Sean Keenan came up with the austere emergency care program, I jumped on board immediately. He invited me on to be on the board of directors of SMS, which he started as a nonprofit, and it owns the Prolonged Field Care Working Group, and it owns the AEC, and now we're slowly pushing Europe to embrace prolonged field care. And as we speak, Sean is on his way to down under, to run it again. So they're picking up progress there, and we're doing, as a college, we're doing everything we possibly can to push the concepts of prolonged field care here in the EU and Europe. So, lads, what interesting developments are coming from the college?
So there's an interesting new development that we've been keeping it under the rug, but I think things are going very well and we can start talking about it. There's a plan of a new faculty called the Faculty of Operational Medicine within the college. The idea basically comes from the fact that since the invasion in Ukraine that happened, operational and tactical medicine drastically changed. The whole view changed. And I do believe that we need to pull together subject matter experts from around the world and within our faculty. And we do not reinvent the wheel, but we put another wheel to it. Because basically the days of global war on terror and all the good support lines and everything is now over. So we're moving in more into the territory of prolonged field care. So since we have seen the second invasion of Ukraine, and that we're basically moving away from the global war on terror, we see that we need to implement new ideas and concepts within the tactical and operational medicine field. And I think the college will be a great foundation to pull together all the subject matter experts and make something new that we can spread.
And I totally agree with you. And there's also some other things that we need to address, because if we have more and more, like if we are incurring something that happens in Ukraine, in other countries also, and also for remote medics, we need to be in the front line of how to do operational medicine.
Yeah, totally agree. Yes.
Another good thing that I'm going to address for what we're doing for the college now, and which we're going to implement already when we have the courses in November, is that we have done a little agreement with 2 companies that we're going to implement some new monitoring devices. So the first thing we have done is that we have an agreement about monitoring an air probe monitor that we've been getting for free from cousins in Germany. They have developed a little earpiece that actually takes live vitals directly into our app, the Medic tool, which you probably heard me talk about earlier for the documentation. But now you can actually get live stream vitals directly into your patient casualty card, and it will take SpO2, pulse, and temperature. And in next month, they probably have an ECG attached to it. So I already made an agreement that we're going to use Medic a digital patient documentation for our training now, so we can see the improvement of having documentation from point of injury back to the stab points or to the clinics and on the route of evacuation. And I think that will be a good supplement to our training in Malta.
One thing that I see the need for is interoperability. And as we transition from the GWAT, the 20-minute magic helicopter coming to take our casualty out, and we're getting into large-scale combat operations, the need for interoperability. And what impresses me with your Medic tool is you can export into a PDF and get it downloaded to a USB and hand it to somebody who doesn't have access to Medic tool, and it's a PDF. And you're not being jerks about it and saying, oh, if you don't have our kit, you're never going to be able to treat a casualty. I'm so impressed with that. And when we talk about interoperability, that is key.
Yeah, I think the key is to make sure that all the things that you are doing is, there's two ways of thinking about it. The first way is that the next echelon of care need to know what happened to the casualty and what was done to the casualty and how did the casualty react or to your intervention, to your drugs, and what kind of drugs have they got. And we have a big problem because all that information is lacking most today. So if you can either get it that people has the same system for the front line, for the stab points, for the evacuation chain, that's a good thing. But also having the opportunity or the possibility to download it or just send you as a PDF via SMS, WhatsApp, and whatever you have.
We need the documentation so we can learn from our experiences.
Absolutely.
So lads, in November, John Clark, our executive dean, will be over in Malta and doing an NEAMT site visit. So we'll become an NEAMT training provider. So Eirik, since you're running all the short courses, and Laszlo, you are running the operational side of things, how is the ability of offering PHTLS, AMLS, combat lifesaver and CMC courses going to change the college?
I think most of these things, like the CLS courses and the NEAMT more operational courses, that you have to answer for, Laszlo. But for me, it's going to be much more work, because I think there's a need for these courses. And when we get approved in November, we will open up for application for these courses. And hopefully, with the new classroom, we have the capability of doing great training, because we don't only have the classroom for these courses, we have big outdoor shooting range that.
Yeah, so Victoria shooting range there in Malta.
And that's a great place, not only the shooting range, but all the obstacles, all the areas there. We can do a lot of remote austere training. And I think that will fit straight into the PSTLS and the AMLS as practice. Because as we try to do in all our teaching, in all our courses, we don't want to do that by PowerPoint. That's why we have all the online courses first, so students can get the theoretical knowledge coming down, and we can focus on hands-on skills, hands-on training, and do the most of that. And that makes the course, in my opinion, much more great than just sitting in a classroom.
So having the NEAMT center for college would benefit us, and mostly it will benefit the students, because let's not forget that NEAMT is the official TCCC provider currently, and all of the courses, the Combat Lifesaver, Combat Medic, all service member courses, these are all evidence-based and approved by the American College of Surgeons and the Joint Trauma System.
So Laszlo, how is this going to affect our remote EMT program? So at the moment, the CLS starts out at ground zero, and it's great that you're going to be doing that for people with no medical training at all. But the CMC is based off of somebody who already has a medical qualification. So how would that work with our REMT graduates?
So basically, it's very simple. So the award in REMT is a very comprehensive basic medical training, which basically they will learn all the necessary skills to function as an EMT, remote EMT. So they will have a good understanding of anatomy, physiology, patient assessment, various illnesses, diseases. So by the time they complete their REMT training course, they will have all the necessary tools to jump in to the combat medic course. Yes, there will be some things that they will already know, some reviews of bleeding control and maybe some airway, but definitely they will need to use all of their skills and knowledge, because within the combat medic course, they must learn about IVs, they must learn about IOs, they must learn about advanced monitoring. So it's really, I would say it would be a step up from the REMT. And I would say that as I see how the REMT courses goes, it will prepare our students very well for the upcoming combat medic course. So they have all the necessary basic foundations to step up and carry on.
So at the moment, the remote TMT is 6 days long, and the CMC is another 63 hours. So we're looking at another week and a half, aren't we?
Yes, approximately. I would say another week. We can squeeze the two courses into 2 weeks, I would say. And mostly, as always, and as Eirik said before, that all of the lectures would be skills based, scenario based, to give them as much hands on as basically humanly possible. And the big plan is to close off this 2 weeks with 2 days of extensive field exercise, to put them out in the field, run them through all the care under fire drills or the tactical field care drills, and basically to do a very good detailed medevac drills as well.
And also, like one of the lectures I had today, which actually just came out, I think it was 24th of August, 23rd of August, the Joint Trauma System just published a new CPG, which called, I can't remember exactly the word, but it's about patient packing and patient readiness for transport, which I think is a great CPG. It covers a lot of the big bullet points. There has a lot of pearls in it, pearls that will tell them some things that people might not think so much about when they are making a casualty ready for transportation or waiting for evac. there are some really important procedures and medical skills that you need to think about before you handle your casualty. So I think that in the CMC course, we're going to implement some of that also.
So that's the en route care patient packaging that dropped a fortnight ago in August. And being a CPG, of course, we're going to review it and implement the lessons learned. And that's one thing I learned, how important it is to base a lot of our learning on CPGs. And Laszlo, with your operational faculty, CPGs are a big part of the CMC. How are you going to implement, or is there going to be a change within the World EMT curriculum to meet and match some of those CPGs found in the combat med course?
I don't think we need to touch the remote EMT course at all, because like all the foundations are being laid down very well in it. It gives them the students a very good understanding. I think it can just carry on, and the CMC can go according to the guidelines.
Lads, my final question for you is, what advice do you have for the new doctor, the new nurse, the new paramedic who is just now starting out on their career in austere medicine?
So I would say to don't be afraid of getting your hands dirty. That means have as much patient contact as possible. And if you're a beginner, if you're a student, and if you're new, don't be afraid to go in and help the local nurses and to ask questions and to be there. My personal experience when I started with my medical field is that the more I helped out the nurses and the doctors and the nurse assistants, basically the more experience I gained from it, and the more helpful they were towards to me, and the more happy they were to share very interesting knowledge and experience. So just jump in there and do whatever you can.
That's a lesson that I embrace. I was told this before I was a Green Beret by an experienced soft medic, and he said, find the nurse, the head nurse or one of the nurses, and do the worst possible task that she has, which is usually wiping things or do it and just jumping in, or start mopping or cleaning beds off. And bed cleaning is so easy to do, and it's something that I learned quite quickly. And then as the dirty jobs that no one wants shows up, I would jump on them. And within a few days, they were like, oh, you're one of those. You're actually motivated. So let's grab you if we have this really cool thing that we're going to do.
Yeah, I totally agree, because that was also my start of the EMT in the early 80s. It's showing the interest. Don't be afraid even to go in and ask, hey, can I then watch you work, or I can help in some way. Just be that guy or girl that is eager to learn and always showing interest, and you will grow. And you will find out that don't be afraid to ask, hey, what is this? If you're standing on a trauma casualty in a hospital and you don't know what they're doing, just ask them. You are there to learn. So if you ask people, they will start talking to you and start sharing their knowledge, because all the doctors, nurses, and paramedics that I have come across, they are also very willing to share their wisdom, because at the end of the day, the more people know about how to treat casualties, the more people we can save.
Well, lads, it's been great to teach with you on these EU soft courses, and it's impressive as my position is stepping back and kind of keeping an eye on where things are going and advising and when needed. It's great to see the two of you grabbing your parts of the CoROM pie and making it better, excelling, bringing in new thoughts and new passions. And I am delighted that both of you are on our faculty.
Thank you. It's a pleasure to be a part of this. I really love it.
Likewise, it's a privilege to be here and to work together with you gentlemen.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at CoROM.com. remote.edu.mt.